else, we're going to go ahead and get started. So, welcome to October 2020 BARHII Data Committee meeting. Hope you've all been well since our last meeting. This month, we've got a few different things going on, but the most prominent is that we have Jason Vargo here from the California Department of Public Health to talk about California's new health equity metric. That's part of the Blueprint for a Safer Economy program. So Jason is going to give a nice presentation on that. We'll have a little bit of time for Q&A afterwards, and then after that, we're going to check in about where you are with COVID and what kind of data situation we can help with. But first, why don't we go ahead and start with a quick round of introductions. If you could say your name, what department or organization you're with, and yeah, we'll just start with that. So I'm Melanie Newcomb. I'm the membership liaison here at BARHII, and I'm excited to be here today.
Hi, my name is Billy, and I'm an epidemiologist with Alameda County HIV.
This is Melody, also an epi at Alameda County working on HIV.
This is Tanvi. I'm an epidemiologist for the city of Berkeley.
Hi, this is Karen Pfister. I'm an epidemiology program manager for San Mateo County.
Hi, and this is Debbie Van Olst, and I am also an epidemiologist in San Mateo County.
Hi, everybody. This is Peter O. I'm with the CDPH Office of Health Equity as well, and in the Health Research and Statistics Unit.
Great. You never would have guessed it, but it sounds like we have quite a few epidemiologists here today. That being said, I think the only person who didn't introduce themselves is Jason, which is kind of perfect because I'll let him introduce himself in just a moment. But like I said a moment ago, we have Jason Vargo here from CDPH talking about the health equity metric for California. And I think I'll let Jason take it away. Jason, are you there and able to speak?
Hi,
Perfect.
my name's Jason. Can you hear me?
Yes.
Okay. Yeah, thanks for inviting me. Thanks. I've participated in this group from time to time, and I'm sure many people on this call have heard me talk a lot about this topic already, but here I am again. I'm usually with the Office of Health Equity at CDPH in the Climate Change and Health Equity work group or program. Sorry, it's a program. Haven't been there in a while, so don't even remember the name of it, obviously. But I've been working on the COVID response with the CDPH COVID science branch for a while now on the modeling team. And so adjacent to that, I think I've just been working on examining the COVID pandemic through the health equity lens, and primarily using the Healthy Places Index tool that you've seen rolled up into the health equity metric that I'll talk about today. So I hope that this isn't too repetitive for many of you, but I wanted to walk through some of the health equity metric, and then I'll try to do that as quickly as possible and just leave as much time as I can for discussion and questions about it. So I'll go ahead and share my screen. Sorry. Can y'all see that? I can't really tell which screen you are seeing.
Yep, we're seeing the presentation side, so you're all good.
Okay, so it's full screen, the slide, you're not seeing the presenter view.
Yes.
Okay, great. So I think many of you are probably familiar with the Blueprint for Safer Economy, which is essentially the framework that was released by the HHS and the governor about a month ago, probably over a month ago now, but essentially defined a tiered system with varying restrictions that would be in place dependent on a county's case rate and test positivity and a health equity metric. And for a couple weeks, that health equity metric was not really defined specifically, but it was just mentioned to be forthcoming. And about 3 weeks ago, the specifics of that health equity metric were released. And so today I just wanted to sort of walk through how the metric is calculated. We're still getting a lot of questions about what some people are interested in what the Healthy Places Index is, why there's a health equity metric. Certainly for this group, I think I probably won't get too many questions about that. But if there are more technical questions about the calculation and what goes into it and how we're doing things on the CDPH side for the blueprint, I'm happy to answer those. So I just do want to give an overview of the Healthy Places Index and why we're using it. I think most people know that it's produced by the Public Health Alliance Southern California. It's available at the census tract level, and it describes a number of different social determinants of health organized into 8 policy action areas, as they refer to them, or sometimes what we call domains. And then those domains are sort of weighted and combined into an index, and the weights are assigned to that index based on the association of life expectancy at birth of the index. So in that way, because it's available at the census tract level, it's very granular. It describes community level opportunities for living healthy lives. It's validated in that it's compared against a health outcome of life expectancy at birth. And the other really powerful part of the website, not necessarily the index itself, is that it is connected to a wealth of resources and policy solutions. So that's always a recommendation of ours, is that as you're looking at the Healthy Places Index, that you go to the Healthy Places Index website to really find out more about what actions you can take, what policies you can pursue to really make progress on these persistent and wicked problems on the ground. As I said, these indicator scores are really a combination of many different social determinants of health. There are 25 indicators that go into these 8 policy action scores, and then they're weighted to produce a final index. You can see here an example of 2 census tracts that are in the Sacramento region that are fairly close together with very different scores. Dark green is really the top quartile in the state on this map, and dark blue is the bottom quartile on this map. And the index is really scaled to vary around that state median at the 0 or the 50th percentile. So when you see values for Healthy Places Index like 0.56 or negative 0.73, they're not always as useful as you might hope, but it should tell you relative to other places in the state, the type of environment that exists there, the type of opportunities that exist for communities there to live healthy lives in that place. And this is just sort of a random Google Street View shot of the neighborhoods that fall in these 2 very different census tracts around Sacramento, just to give you a sort of on the ground picture of what the Healthy Places Index is capturing. In our case, we started looking early at how COVID rates were sort of playing out by the Healthy Places Index. I mentioned that it's available at the census tract level, but in this case, in this figure, I'm showing one of the social determinants of health that goes into the Healthy Places Index, median household income at the county level. And I really want to illustrate, I just show this to illustrate the value of really looking at the granular data that exists within the Healthy Places Index. A lot of the reporting, of course, as many people know, on the governor's dashboard, different CDPH pages, a lot of the reporting is done at the county level or the local health jurisdiction level. So people are familiar with seeing case rates that might be, 5. In this case, I'm reporting per 10,000, but often we're reporting per 100,000. But these case rates shouldn't be that unfamiliar to people. But when you look at it at the county level with income, for example, you see that it would tend to indicate that there's a trend here as income is increasing in the county, the median household income, that the case rate would be increasing with income, perhaps implying that there's not really an association between the inequities that the Healthy Places Index is capturing and the COVID disparities that we're seeing on the ground. But when we look at it at the census tract level, we see that trend going in a completely different direction. So the figure on the left are the same two metrics, just examined at the county scale, and the figure on the right are those same two metrics, case rate and median household income, examined at the tract level. And you can see there that we see a very different relationship with the highest case rates appearing in the places, the communities where we have the lowest household income. And this is sort of exemplifying what we were seeing early on in the case record data, and went along or sort of corroborate what we understood about social determinants of health and its intersection with race and ethnicity in the state. So another way that we've looked at it is just to look at the Healthy Places Index rather than to look at income or education, for example, just to look at the sort of initial, is the Healthy Places Index helping us to understand something about case rates? In this case, again, I'm showing case rates on the y-axis and different groupings of census tracts based on their Healthy Places Index on the X. So the 10% of all the census tracts fall into each of these sort of bars that you're seeing. And you can look at the range of case rates in the census tracts in that group, and then the median as well. And you see this sort of gradient as the Healthy Places Index increases. And just a reminder that higher values of that index mean greater opportunity for living healthy lives. Typically, that means higher educational attainment, higher income, better access to healthcare, better home ownership, less severe renter burden, improved neighborhood amenities, and decreased pollution. We see as the index increases, lower case rates in those places. And we did this, we sort of went through many of the social determinants of health in the Healthy Places Index and saw this gradient sort of repeating itself over and over. And this led us to not only really want to focus on these upstream root causes of health inequities and disparities that we saw in the pandemic, but also to sort of focus on using an index because we know that it's a combination of many of these things that are contributing to the circumstances that put certain communities at much higher risk of contracting COVID and getting sick. And I will say that this will probably differ from place to place. And I know I saw some analyses that Contra Costa had done where they began to sort of explore within their own county which of these might be contributing more or less to the disparities that they're seeing. So that's definitely like something that we recommend is, even though at the state level we've selected to use this overall index, you can sort of pick it apart and begin to go deeper into it to understand your unique situation in your own county. So I'll just quickly talk about the actual health equity metric. And now that you know that we're using the Healthy Places Index, I want to talk about exactly how we do that. So it's essentially, I like to break it into, I guess, 2 or 3 steps. If you're reading the text on the bottom half of the screen, it looks like 2 steps. And if you're looking at the diagram on the top half of the screen, it looks like 3. So already it's very simple and clear. So I'll just say that we try to use the HBI to describe differences in health equity across a county. So while the actual Healthy Places Index, if you go to their website, they're talking about comparing the whole state of California. For this metric, we're really focusing and applying it sort of county by county. So we're looking within a county. So we take all of the county census tracts and we assign this Healthy Places Index quartile based on the index scores for the tracts only in that county. And then we look at the bottom 25 or the bottom quartile or the lowest quartile. And then we look at the tests and the positive tests in that quartile to calculate the health equity metric. So essentially we're taking a test positivity that's for a subset of the county and using that as the health equity metric. So we sum the positive tests and the total tests that appear in that health equity quartile. And then once you divide them and multiply by 100, you have this test positivity, test over test positivity for that quartile. This is exactly the same calculation. I'll walk through that in a minute. This is exactly the same calculation that we use for the overall county-wide test positivity in terms of, which tests are excluded and how the tests are reported to CDPH. So this excludes tests for persons out of state or with unknown county. It excludes tests for persons who are incarcerated or in state and federal prisons, ICE facilities, and Department of State hospitals. And it's a 7-day total. We use a 7-day total and a 7-day total for tests with the 7-day lag. So it uses specimen collection date and it only right now looks at PCR tests. I don't know the status on antigen tests at the moment. The data source is CalReady in LA County, the ELR data that California gets for its for the data that CDPH gets in terms of its electronic lab reporting. Sorry, this is for overall test positivity. This is the one that we use where we take the total number of PCR tests for COVID-19 over the 7-day period, divide by the total number of tests that are in that record, and then multiply by 100. So this is, depending on the geography, this is the same calculation. In one blueprint metric for the county overall test positivity, it's performing this metric for the entire county. And in another metric for the health equity metric, we're performing this calculation for all of the census tracts in that health equity quartile. As I said, there's some specifics of the testing. Again, all tests, including retests of the same person, are counted. This is a test over test positivity rather than a person over test positivity. So there are some different ways you can calculate test positivity based on deduplication and so on. This is the same method that CDC is using, for example. So this is just a simple example of how we apply it. This is a hypothetical county here, and you can see that it has 19 different geographies. We'll call them census tracts. So 19 census tracts, and assuming they all have a Healthy Places Index value, we rank them from low to high. And then because we have a number that's not equally, or it's not a multiple of 4, it's not equally divisible by 4, we're going to have different numbers of tracts in each group. We assign those remainder census tracts to the lowest group first. So quartile 1, 2, and 3 in this case will have 5 census tracts. Quartile 4 has 4 census tracts. But essentially, once you've ranked those tracts, you assign them to quartiles based on that score. And then you quickly know that 10, 15, 9, 19, and 3, or the dark blue census tracts on the right map, are the ones that are going to be used for calculating that Healthy Places Index health equity metric. So to do, I'm sorry?
Oops. Sorry. No, I was reading an email. I apologize.
But you feel free to disagree if you.
No. I don't disagree. I really apologize.
Well, thank you, because that gave me a chance to take a sip of water there. So then once you know which census tracts are in the health equity quartile, and you just need to know which tests are associated with that with residences in those census tracts. So if you know that, you sum up the number of positives and divide by the sum of the number of tests, and then you multiply by 100 and you have your test positivity. So there are two ways that this could be done. Essentially, we do not do this method on top, which is calculating each census tract's test positivity, for example. So we don't assess each census tract's test positivity individually and then average them, which would be this method on the top. Rather, we pool these census tracts that fall into this health equity quartile and then consider them together. And essentially, that's important because, for example, if you had one census tract where you had a really, perhaps a smaller sample or a lower number of tests, for example, census tract number 9 in this hypothetical example, you may see a test positivity that may have oversized influence on that top method, which is X out. But essentially, doing it this way helps us to sort of average them, weighted average, essentially based on the number of tests that each census tract is contributing to that health equity metric. This is just a slide that goes into a little more detail about why or what we're doing in terms of comparing our method to what you might see on the Healthy Places Index page. The main difference between what we're doing with the health equity metric and what might appear on the Healthy Places Index page is that we are assigning quartiles to census tracts based on the distribution of Healthy Places Index values within a county. So for example, in this county, I know which county it is, but you probably do not, because I've removed the names to protect the innocent. But this county has about 600 census tracts. So now some of the people on this call probably know what county it is. But essentially about half of those 600 census tracts have a statewide HPI score of below 50. So if you looked on the HPI website, you would see a lot of these census tracts that are in the bottom quarter of the county census tracts are about in the bottom half of the state census tracts. This essentially means that like a lot of the Bay Area counties compared to the rest of the state, there's a fair amount of wealthy census tracts. A lot of the coastal counties have large populations and concentrations of wealth, and in many ways that translates to higher health equity scores. So you see this skewing in many counties in the Bay Area toward this higher scaling. And so rescaling it helps to identify within the county where are the biggest differences between parts of the county that are having low Healthy Places Index scores and parts of the county that have the highest Healthy Places Index scores. So for example, in this example again, about 3/4 of the county fall above the state median. And it's really important for us to understand that in this county in particular, we don't want to exclude this proportion of the census tracts from the calculation of the health equity metric. When we did this over and over, when we repeated this methodology and examined sort of using the state versus using a county specific ranking, it was important importantly, we found that over and over, it was associated with test positivity. So we did sort of continuously see elevated test positivities in the places respective to each county, which had the lowest HPI scores. And I think many of you may have seen maps like that or plots like this, where we're sharing test positivity trends for that health equity quartile, which is the dark blue line here, and the other blueprint metric of the countywide test positivity health equity metric. And here you can see the 9 Bay Area counties, and I've added the BARHII region here in that same presentation. So you can see how the health equity quartile has behaved over the last 6 weeks in terms of test positivity, and how the overall county test positivity has also behaved. It's been a lot of recent good COVID news that gap has really been narrowing in a lot of places, and you can certainly see that here for the region, that about 6 weeks ago, the gap was much larger. Definitely test positivity for the 2 different geographies were appearing in different tiers according to the blueprint, and now getting closer together, nearly in the same tier. And there are a number of ways to go about sort of reducing test positivity. Just the basic nuts and bolts and mechanics of the calculation would say that the simplest way is to either reduce the number of positives or to increase the number of tests. And so that's one reason that sort of feeds into the next step of the process, which is the targeted investment plan about how what actions can be taken, what actions are going to be the most useful for a county in trying to make progress on the health equity metric. Specifically, I would say to reduce the number of positives and health. I would say that CDPH is really pushing or hoping to support sort of all of government approach and health and all policies approach in trying to make progress on that, because I think that's what most people on this call would agree is required to do that. I just also wanted to show this. We have been looking at, this is kind of, you get to watch this a couple times, I think, to get it. But this is sort of showing over time in the pandemic how test positivity in the lowest HPI quartile, which is the dark blue cross, and the highest HPI quartile, which is the dark green cross, have sort of diverged. Especially, we see this, there's a certain pattern that I think we observe over and over by looking at these for different counties, is that you really see the divergence, in April and May, the stay-at-home order. And this was also some early work that we did using HPI, was to look at changes in stay-at-home ability and mobility by around the stay-at-home order. And so where you see that divergence, there was really a difference in the number of positives, again, the sort of how far these crosses are up or down. But I think it's encouraging that you do see the testing volume for the 2 portions of the county really moving together, the left to right. These crosses tend to stay about the same, so that they're moving together in terms of like testing volume, but it's really about the number of positives. So at least this is really, I'm only showing this to sort of hopefully foster discussion amongst this group, but I think it's pretty interesting that we're seeing fairly similar testing volumes. Of course, the scale and the community to community, it will look very different, but across the state, this is a pattern that we've seen over and over, and it really emphasizes the need to sort of think about how do we really assist in transmission and not just testing capacity. I think that's the real crux of the issue.
Can you just say just restate what that was showing? Because I don't think I maybe know how to read this chart.
Sorry, it's really, it makes sense to me, but I might be the only person. So essentially the purple to the red and orange and yellow, those are the tiers. And if we plot, so any combination of number of positives and number of tests will get you a test positivity, and the test positivity would be in one of these 4 tiers. So if you have, 10,000 tests and you have only 200 positives, you might be right about here. So for any date in the last like 5 months, we can look at how many tests had happened in a portion of a county and how many positives were in a portion of a county. And if we define those portions by like lowest HPI and highest HPI, we can get these 2 lines effectively. And so this just sort of runs through the months since March 1st to present of those 2 quartiles and the test positivity over time. So it gives you it's similar to what I'm showing here. But in this case, I've sort of dissected the two numbers that go into a test positivity calculation, that numerator on the y-axis and the denominator on the x-axis.
The little arrows are showing what? I guess I can't see them that well. Maybe they're crosses.
Yeah, that's just to give you a sense of like the history of it. It's sort of like a breadcrumb or something.
We don't know why it diverges in that way.
No, I mean, we don't know for sure, but like I said, when you look at when we've looked at the patterns in mobility and or the ability of certain communities to sort of follow stay at home or have to go to work, as essential workers and for workforce, we saw that divergence in these same categories of communities. So we looked at it. I should have said that differently, I think, but we looked at how much time folks in the low HPI and the high HPI could spend at home, and not surprisingly, the highest health equity scores are communities where people have like better healthcare coverage and paid leave and opportunities to telework and things like that. And so they're able to stay home in a way that other communities are not able to. And so, I mean, that's a hypothesis that I think that's something we should talk about on this call if people are interested to. Quickly, I'll just wrap up. I know I'm probably over my time, but the health equity metric is really, there's 3 things I want to say about the way that the health equity metric fits into the blueprint. The first is not really on this slide, so I'll just turn it black. But the first is that the health equity metric cannot be used to move a county to a more restrictive tier. Only case rate and overall test positivity can do that. So the other 2 ways that it can be applied are to hold up tier progression if until a county has made sure that all of essentially the idea is that a county can move forward once it demonstrates this progress in the health equity quartile as well as in the county overall. So if you're in widespread and substantial, you have to meet the case rate and the test positivity criteria to move to substantial level. But also in your health equity quartile, you need to meet this threshold. So this is exactly the same as the county overall test positivity. For moderate and minimal, it's, I think, a 5% sort of buffer on top of it, which I don't know how that's agreed upon, but it is. Those are the rules at the moment. The other way that it applies to the blueprint metric is as sort of an incentive to assist counties who are really performing well in the health equity quartile and the test positivity rates there, but maybe experiencing higher case rates. So for example, if a county is in widespread and it has a test positivity both countywide and in the bottom quartile of the HPI below 5%, it can progress to the next less restrictive tier, despite having a case rate that is still in the purple or widespread tier. And then for moderate, it's similar. It gives you, it's an incentive. So counties with a moderate status meeting for 2 weeks test positivity, both countywide and in the HPI quartile, below 2% can progress to the bottom minimal tier if they have a case rate less than or equal to 2. So these are some of the rules on how this is applied. And the last 2 slides are really about forthcoming resources, I would say, from CDPH and the Office of Health Equity to help with this. Never a dull moment in COVID. And but there are a number of strategies that they're putting together in a playbook for communities. So there's a working draft right now, but I expect that to be coming out pretty soon. Really, again, focusing on all of government approach, really talking about the different tenure or term of strategies, making sure that that it's recognized that the conditions that created these disparities that we're seeing in case rates for COVID are long-standing issues and are not going to be solved by the COVID response alone. I hope that if there's anything, that there's a legacy of this health equity metric that really sort of solidifies an approach to addressing public health disparities that we see on the ground. It would be great. And then finally, CDPH is going to be standing up technical assistance hubs that will provide technical assistance to counties and local health jurisdictions, hopefully connecting people who are on this call, local health jurisdictions, the EPIs, the local health officers with resources, expertise, and even philanthropic funded efforts to help make progress on the strategies that are outlined in the targeted intervention plan. So I'm going to stop there. I'm happy to go back and talk about any of the materials that I went over, or to answer questions, or just to sort of hypothesize about COVID. So thanks for your time.